In recent years, health providers and policymakers have recognized the high personal and financial costs of readmission to the hospital. Health policies have changed to promote better care to avoid hospital readmissions and assess penalties to hospitals for failure to provide better transitional care services. A key program being adopted in Oregon is the Care Transitions Program. Although it is not available in all communities, some of the steps they take are consistent with some of the things that Susan Dentzer talked about. The Care Transition Program involves helping patients and their families schedule and complete follow-up visits with a personal physician, ensure that medications are correct, learn to recognize warning signs that the condition is worsening, and have updated personal health record to facilitate communication. People with dementia are at high risk of delirium. Delirium is sometimes confused with dementia because it is associated with confusion, disorientation, and impaired cognitive function. However, it is different than dementia in that its onset occurs within hours or days, and it can often be reversed. The consequences of untreated delirium are severe. It should be considered a medical emergency. The Mayo Clinic defines delirium as a serious disturbance in a person's mental abilities that results in a decreased awareness of their environment and confused thinking. The onset of delirium is usually sudden, often within hours or a few days. Delirium can be caused by many things. Medications is one of the most common and occurs when various medications have adverse interactions or dosages of medications that haven't caused problems in the past may be a problem now if the person has lost weight or has had other physical changes resulting in changes of the way the medications are metabolized. Anesthesia is another common cause of delirium. Primary care providers and nurses can consult with pharmacists to determine the extent to which medications are leading to delirium. Infections are another culprit. Urinary tract infections is a common source. Infections in the mouth or pneumonia or other illnesses can be causes as well. The major risk factors for delirium are age, dementia, and frailty, and the risk of delirium increases as dementia progresses. The symptoms of delirium and dementia can be similar, and information from a family member or caregiver may be critically important for a doctor to make an accurate diagnosis. The symptoms in bold should be an indication that evaluation for delirium is warranted because these symptoms are different than symptoms related to dementia. These include rapid onset, inattention, and fluctuating symptoms. That is, when a person seems to track at one moment, not at the next, and then can track again. Delirium is pervasive in hospitalized older adults, particularly those with dementia. It occurs 4 to 5 times more often in people with dementia than other older adults. Research indicates that most delirium goes untreated, unrecognized, and it can take weeks or sometimes months to treat. The consequences of delirium frequently are life-changing. Even with treatment, it is not unusual for delirium to lead to permanent cognitive and physical decline. Delirium can start a downward spiral of deconditioning, which contributes to falls and incontinence. Malnutrition is common, and so is poorly managed pain. About a third of those who acquire delirium will die from its complications. Dennis had congestive heart failure as well as dementia and was hospitalized. His daughters were able to advocate for Dennis when he was in the hospital. In part, this was because Sally was knowledgeable about delirium. Let's see how she describes this situation.
This hospitalization was really difficult for all of us. Dad had never been mean or aggressive, just, kind of ornery with us. But he started shouting and hitting nurses in the hospital. I think he was really frightened, but he was also saying some really weird things about what the doctors and nurses were doing with patients in the next room. Now, this was really different. And at first, the staff didn't seem to find it concerning. They said they had experience with people with dementia, and, they'd soothe and reassure him, but I think they also sedated him so he would sleep. I called the options counselor because I remembered that she gave us some information about what to do in case Dad had to go to the hospital. So she reminded me about delirium, and she resent some information about how to identify it in people with dementia. So I took that information to the hospital and insisted that they check him for it. Man, Lola really helped here. She kept calling his doctor. She looked up articles, and between us, we finally found someone who would listen and understood that Dad's behavior was really different, and it wasn't just because of the dementia. So once he did the assessment, then they could figure out what was wrong, and they helped get his system back into balance. And he's much better. He's not quite the same as before. I mean, his balance is worse, and he's more confused. Can't be alone. We've increased hours for the home care workers, and my husband and I are sleeping here a couple of nights a week. We'll try it for a while and see if Dad can get better. Oh, Lola's coming for a week in a few days. I'm really glad we did all that planning. I know which assisted living community Dad likes the best, and I'll talk to him in the next few days. I mean, even if it works at home for the next couple of months, I know it's time to be getting ready for the next stage.
The most important thing that Sally and her sister did to advocate for Dennis was to insist that major changes in behaviors had happened quickly and that they changed throughout the day. They also insisted that the medications used to sedate Dennis in the hospital be reduced and further evaluated by the pharmacist to determine if they were appropriate for Dennis or if they were contributing to the delirium. The ADRC helped to prepare Dennis's family for hospitalization by providing information about delirium. The options counselor had mentioned it to Sally, and other things options counselor can do are provide tools for preparing for hospital admissions if possible. Families are really important in providing person-centered information to hospital staff. Options counselors can help families advocate for the person with dementia, coaching them to ask about delirium, what the hospital is doing to prevent delirium, and signs for the family and staff to watch for to identify it as early as possible. The options counselor can also connect people to transition care services, whether through the ADRC or the hospital discharge system. More information about delirium and people with dementia is available through the Consult Jerry RN website. This includes assessing pain in people with dementia, wandering in hospitalized older adults, and assessing and managing delirium in persons with dementia.